which we'll be doing a couple different retreats. I'm Lisa Bowie, your Quality Improvement Director / host for the meeting. This is, yes, a December official meeting. Let's do a couple of your tips for the meeting as always, and we'll get right into it. Please remain muted when not speaking. If you're joining by phone only, please do *6 if you're having trouble unmuting. If you can, use the raise hand function, which is under the reactions button on your Zoom panel. And as a reminder to state your name and your organization when you're speaking. Next slide. Just a reminder of where the buttons are. So you will need to connect your phone and your computer. So if you're joining by 2 different devices, you'll need to do that today because we are doing breakout rooms. Next slide. Agenda. We are going to do a slight change in the agenda today. So just a note, we are flipping things around due to a couple attendee changes. So we're going to do the HERC update right after the announcements, and then EPSDT will follow. So depending on how long the HERC goes, we'll just kind of be fluid of when the break will be, but you'll get a break. And then we'll do EPSDT sometime after 10:30. And we'll just figure out when the break will be. Next slide. Announcement, just a couple announcements. The partnership, SHIP standing for State Health Improvement Plan, otherwise known as Healthier Oregon, is seeking a new CCO representative. I believe in the summer, early fall, we had a representative and then that didn't work out. So the partnership is seeking a new CCO representative. If you click that hyperlink in the meeting slide, you'll get more information around that. And then as Roger Citron mentioned at the last meeting and regularly, the Pharmacy and Therapeutics Committee, P&T Committee, is seeking medical director representative. And again, that blue hyperlink gives you information about the P&T Committee. So both of those committees are looking for representation. So if you can continue to get that message out. Any announcements, Jeannie, Doug, Dawn, other than those 2?
No, I would just say, from our conversations and from the CCO medical director world, I think we're looking forward to continuing to learn more about the EPSDT today. And, also looking at the HERC and the P&T committee and hoping we can get great representation there. So that's about it.
Okay, Jennifer, if you wouldn't mind, go ahead and just skip ahead to Ariel's slides for the HERC.
Hey, Lisa, this is Roger Citron. Can you hear me?
Oh, yes. Hi, Roger.
Hey, good morning. I know I'm not on the agenda, but I just wanted to respond to the announcement you just made. We actually had a couple physicians submit some applications. So we're really excited about putting those forward for consideration by the OHA for appointment. So I just didn't want anybody to go to great lengths to be filling out the applications at this time. If we don't get to move forward with those that have expressed interest, I'll let the committee know when I probably provide my updates next month. But just wanted to let you know.
The moment that I go and put it on the announcement formally is when, of course, you don't need it.
Well, I appreciate you doing that, and your third eye came through, so thank you.
The third eye. Thanks, Roger. Holly Jo.
Yeah, Roger, I just wanted to ask, so at one point there was going to be 3 to 4 openings, and so you have enough people now that all of those openings have been filled?
We had, 2 openings for physicians, and we have had 2 physicians actively practicing that have expressed interest that we're moving forward with recommending for appointment.
Great. All right. Thank you.
Thank you.
I will be confirming just well, this is all good interest. Good job, everyone. I also serve on the Patient Safety Commission. We have a hospital administrator position open, I believe, but I will confirm that on Tuesday, and I'll let y'all know if there's still a position there. So since Rogers is looks like it might be getting filled, I'll let you know if the Patient Safety Commission board has an opening. So if you all think you have people in mind that you thought were for P&T. I'll let you know if the Patient Safety Commission Board has an opening, and then I'll loop back. Okay, I think we're going to go back over to Ariel. So you've got the floor.
Good morning, everyone. I'm Ariel Smits. I'm the medical director for the Health Evidence Review Commission, and I'm bringing you your December update slides. Next slide, please. And we had no public health codes, no new COVID codes. I think this is only the second month in the last 2 or 3 years, so yay. Next slide, please. So our VBBS and HERC both met in November. We discussed several topics and didn't make any changes, including non-coverage for kyphoplasty, non-coverage for biofeedback, and non-coverage for pneumatic compression devices for lymphedema. We talked about corneal collagen cross-linking, which is a ophthalmology procedure for keratoconus, which is a thinning outer layer of the eye. We added the CPT code for this procedure, which is a T code. And then there's a J code for the actual riboflavin medication that there's been a lot of work going on behind the scenes to see about opening that. So just to let you all know, the intent is to cover this procedure starting in January. It sounds like a lot of CCOs already are, but we're having a lot of issues with the J code because the company doesn't give a rebate to Medicaid or CMS, so we are not able to cover it. So if anyone has a good workaround for that, please let staff know. We've been working with the providers and with the pharmacy folks and kind of running into dead ends. So that would be really helpful. And we have been told there's only 3 or 4 providers in the state that do this. We've been told that some of the CCOs are already paying for this. So however, if you are doing it, please let me know and how you're getting it paid. Next slide. We looked at the 2023 CPT codes. It was a little shorter set than usual. There are only about 75, 80 codes. They are available on our website. There should be a Excel spreadsheet you can download. They're also in the minutes that you got. So you should be able to see the placement. So there were multiple straightforward codes that were just variations on currently covered procedures, or were just pretty straightforward diagnostic tests, or pretty straightforward other kinds of things. So those are in the spreadsheet. We looked specifically at a few new codes, most of which we determined were experimental, which is kind of normal with new CPT codes. Absorbable mesh or prostheses for delayed wound closure. Looks like there's actually worse outcomes with this than non-absorbable mesh and other treatments, so we elected not to cover it. Same with radiofrequency repair of nasal valve collapse. Nasal valve collapse surgery itself is below the line, and this is actually a pretty new therapy that doesn't have a lot of evidence. Gastric balloons, we've always indicated that we don't cover them. There is actually now a specific code which hadn't been present previously, so we've added an entry to our guideline note 173 just to make it even more clear that we don't cover them. There is a hepatitis B quantitative antigen test. So we cover the qualitative, which is just to see if you have an infection with Hep B or not. This is a quantitative, kind of like your HIV quantitative tests, and it's used to follow along with treatment. So it's on the hepatitis line, and it's probably got a very limited use, but it's not a diagnostic test. It's a test for people who are already diagnosed or under treatment. This one makes me sad. An RSV vaccine code was released, but there is no RSV vaccine. There's nothing that is in the pipeline that's going to eminently get FDA approval. There are multiple vaccine candidates being studied, generally for adults, but none of them have approval. So since there is nothing out there that currently we could even cover if we wanted to, we are excluding this code. Exclusion will allow us to move it to like ancillary or some other file to open it if and when the FDA approves a code. But right now, if you get requests, for example, for children who people want RSV vaccination, there is nothing that's FDA approved, so we can't cover it. Orthoptic training we don't cover, so the new code will go in, or actually we do cover, I'm sorry, for a very, very limited indication in a guideline. So we just added the new code there. Quantitative pupillometry, you can just use a pen light to see if someone's pupils move much more cost effectively. So we put this on line 662. Next slide, please. So we looked at the codes that we were aware of that were HCPCS codes for 2023. And you'll see in a second, there are more that we've just become aware of. But the ones for vaccine counseling, doula codes, and home COVID testing were all covered. Hydrocele repair in adults, we added coverage with modifying the current guideline. Eosinophilic esophagitis was added to the line that allows long-term PPI therapy. We heavily modified the human growth hormone guideline, and we did some housekeeping things for botulinum toxin for strabismus. Next slide. We did not add any new indications for acupuncture. We did add some new indications for PET scans that you can see here. And we defined what we mean by an apneic event. We were using the CMS criteria that you have a greater than 4% desaturation for your AHI calculations. And we added some wording about when we cover repeat sleep studies. And I don't know if you're all aware, but AHRQ just published a week or two ago their final report on CPAP for OHA, which is a very interesting read. I would definitely pull it up. Interestingly, they weren't able to determine there's any evidence for any coverage of CPAP at all. So we might be taking this up again, although there is no evidence that it is ineffective. There's just lack of evidence of effectiveness. So we'll probably not take away coverage. Just so you're aware that that report's out there. Super interesting to read, and I would highly recommend it. Next slide. And then the Health Evidence Review Commission approved the changes from the VVBS meeting, and also went through our, we had a policy for QALYs that went out for public comment. What we are planning on doing is trying to get together with disability advocates and just really have a listening session to figure out what their main concerns are, because it really felt to the HERC members that our current use of QALYs is really consistent with what they want to use or would like us to use. So we're trying to sort that out behind the scenes. Before I go on, are there any burning urgent questions about the November BPBS and HERC meetings? You can just throw it in the chat, or you can also talk at the end if you don't want to speak up right now. Okay, next slide. So our next BPBS and HERC meetings are January 19th. We're continuing to do virtual meetings for this foreseeable future. So if you want to take part, it makes it pretty straightforward. You can go to our website and just sign up to attend the meeting, and it's from your comfort of your office or home. We have our usual consent agenda. There's a couple of topics that we've looked at that are no changes recommended. One is the Afirma test on thyroid biopsies. It doesn't seem to add benefit. We also just reviewed, and it's not on this slide, the 4K test for prostate cancer biopsies. And based on expert input, we're going to continue recommending non-coverage. Then I told you all that we have become aware of new HCPCS codes. It seems that CMS has changed the way they're doing HCPCS codes, and they're kind of doing them on a rolling basis, and they are kind of just coming out with them, and they're effective the next quarter. So there are a series of codes for cardiac testing that you'll see there. There's one for OR use for dental treatment that we're working with our dental oral health group to determine best placement. And then there's a couple of interesting behavioral health related ones. One is CMS is attempting to kind of enshrine the public health emergency leniency on virtual visits for mental health and substance abuse. So they have 3 new codes for that, and we're working with our behavioral health group to determine best placement. They'll probably be on all the behavioral health and substance use lines. And then there's some chronic pain management codes that we also think are going to be really useful, and we're trying to determine best placement there. They are specific for chronic, not acute pain. They'll either be on all lines with E&M codes, or we have an ancillary guideline currently about chronic pain management and what we kind of are envisioning or hoping for. It may be mentioned there, and we may leave it ancillary. If any of you have any opinions on that, let me know. And expect these kind of HCPCS codes, they're going to be rolling out, even though we don't have, we publish our list January 1st and October 1st. This new set of codes may not appear until October 1st unless we publish an interim list. But just to be aware that we will put the recommended code placements on our website so that your organizations can at least see the intent and be able to open them earlier than when a new list is published. Next slide. Other topics on our VBBS agenda, we are going to add some limited coverage for IUD treatment for endometrial cancer. This is not standard of care, but it is acceptable for women who aren't able to undergo surgery because of comorbidities or other issues. It's at least a partial treatment, if not the definitive treatment. I've been working with ENTs on our cochlear implant guidelines. We are going to change a little bit of our definition for what qualifies for getting a cochlear implant based on hearing. CMS and the ENT guidelines have kind of moved away from an absolute threshold of lack of ability to hear with decibels and a little bit more to severe hearing loss and also lack of expected language development in kids. We're going to try to update that. They've updated some of the wording for adults and what kind of testing qualifications they might have. And then there's some discussion going on with both industry and with the ENT providers about unilateral deafness cochlear implants. We currently specify we only cover bilateral deafness for a cochlear implant, but we will hopefully be at least addressing that at our January meeting. There's some our urinary incontinence guideline we're updating a little bit based on provider input to kind of bring it more into current practice. Prurigo nodularis is a really rare, very itchy, very disruptive skin condition that has had new medication that has received FDA approval. It's currently a not covered condition. We're going to be moving it to a covered line. It will be part of our inflammatory skin disease guideline. And then we have been looking at our tonsillectomy guidelines. There are updated ENT guidelines for when to do a tonsillectomy that actually came out in 2019. If any of you have a good understanding of what these guidelines are trying to say, I have been kind of struggling and trying to get ENT to give me some input into what the actual intent of the guidelines are. It's really unclear if how they're changing the definition of what constitutes a strep or an event, a strep infection event, which we currently require to be either a positive strep test or a course of antibiotics prescribed. It may be that they're just saying you need to have a physician or a provider encounter that says that you have an infection or something. It's really unclear. So if any of you all have a good ENT who's responsive, or you have thoughts, if you've already looked at this guideline and worked through it, please get in touch. Next slide. And then these are more issues for discussion. So the thyroid one definitely is out there. We are also working on, currently there is a legislative mandate for private insurance and then the state PEB-OEB programs to cover 12-month contraception at one time. So you go in and you can get all 12 months of your oral contraceptives, for example. We are trying to do a similar type of coverage for the Medicaid program. And if any of you have input or thoughts on if your CCO has already done this and you've got a good way of implementing it, please let me know. Then diagnostic hysterosalpingogram. This Holly Jo Hodges has had a couple of requests for this for things that are not infertility related, that she's approved by exception. I've asked some of the other medical directors who are on our sort of test group whether we should consider this for more or consider this for coverage. We currently exclude it, and it sounds like the general gestalt is that 90 used for infertility, the other a couple of tests that are appropriate can be done as an exception. But if you have feelings that it should be covered as diagnostic, particularly if you have like a very limited set of when it would be covered, it could use as a guideline, please get in touch. We've also been asked to look at facial angiofibromas, which are sort of tumors seen on the face, particularly in tuberous sclerosis. There's a new medication that's been approved, but they aren't giving a rebate, and we aren't allowed to cover it. So currently I'm not going to do anything. I'm not going to propose covering this particular diagnosis, but again, love any input if you have any thoughts on it. And then the other thing that EBGS, our evidence-based guidelines subcommittee, has been really struggling with is continuous glucose monitoring. They're redoing the coverage guidance on that. We currently cover CGM for type 1 diabetes. We don't specifically cover it for type 2, but there's sort of a middle gray zone of people who don't have type 1 diabetes, meaning they don't have an autoimmune attack on their pancreas that destroys the islet cells, but they might have, for example, have had a pancreatectomy, so they don't have obviously islet cells, or they may have had multiple bouts of pancreatitis, or they might have something like CF that can destroy the pancreas, and they might not have working islet cells. So basically, we're trying to figure out where that ground is, where there is sort of the type 1 equivalent group. They might either be in this, there's a ICD-10 set of codes for other diabetes, or they might be type 2 diabetics who kind of qualify, but we're really struggling there. So if any of you have operationalized that or thought about it, I would really appreciate the input. So those are the issues that I would love to hear from all of you about. Next slide. So EBGS, as I mentioned, is working on continuous blood glucose monitoring. They're planning on discussing that in January, as well as updates to their bariatric surgery scope. We are looking at biomarkers for cancer. We're actually trying to get just a work group together to help staff even figure out the directions for this. Biomarkers for cancer are tests on cancer tissue for specific genetic markers that would usually kind of let you have tailored therapy, and we have very specific guidelines about them, but this is a hugely fastly changing area, so we're trying to figure out what's the best way to kind of monitor and update ourselves on that. They're also looking at chronic disease self-management programs, and we are waiting on a expected med report for remote patient monitoring apps and things like that. So that'll be coming down the line in the future. But any other topics that you think EBGS should look at, we are always welcome to your input. Next slide. You know the HERC.info email, please send questions to that. We really actually appreciate your input. It helps us to realize where we have things that aren't up to date, or where we might have mistakes, or where we need to look at things. So please don't hesitate to send questions or requests for review. And then Jason, Amy, and myself have specific emails that at some point will change. We'll update you on that. So that is the HERC report. And I will also be available during the EPSDT discussion if anyone has specific concerns for HERC about EPSDT. But any questions, any input, thoughts, anything about the VBS HERC issues to date?
Nothing in the chat string yet.
And if any of you have just feedback that you want to give later, I'm always happy to receive emails. So,
hey Ariel, this is Jeannie. In my practice as a family medicine physician, I've seen a lot of children now being diagnosed with type 2 diabetes, specifically in the 9 to 11-year-old range. And I'm wondering about the CGM usage for kids, because it's type 1 was approved, I believe, but type 2 is not for coverage that I know of, or I don't know what you guys have looked at But in kids, I think that's a specific issue. And wondering if you guys have seen anything or going to look at that specifically.
Yes, we have.
Leah's watch just checked in. I can see
Sorry?
exactly where she's at in this.
Hey, Kristen, I think you're not on mute. Ah, there you go. Thank you.
Thanks.
Go ahead, Ariel.
But yeah, Jeannie, we have thought about children, and there is obviously the EPSDT requirement for individual review. And I don't have a lot of input to give you all right now, but children have some special needs. They might not want to do the finger pricks because they hurt. There may be more caregiver parental involvement in managing blood sugars. So there might be like the use to have the CGMs go to like phone apps and things. So it might be helpful for parent. Those are all things to consider. They might not be able to prick their fingers in school also because of the need to have like a safe disposal for the needles. So those are all good points to consider when you're looking at that for review right now. If a kiddo just has sort of like garden variety type 2, where you're just basically giving them diet and exercise and weight loss advice, I don't know how helpful the CGMs would be. If they're on medications, definitely would be something to consider. But yes, I will pass that on to Amy and Jason that are working on that much more in detail to make sure that they address kids.
Yeah, I think that would be great, because I think even in the, for these really out of control or high hemoglobin A1C kids who are really on the borderline, or are being diagnosed and are checking their blood sugars 3 to 4 times a day, approval for short periods of time to at least get blood sugar under control, et cetera, seems very reasonable. And we can do all of that individually with individual review. But I think once again, that it creates an administrative burden for our PCPs who are seeing these kids. And if there were a guideline or some sort of, nuance that talked about with kids, like maybe establishing good control and so forth, it might be helpful. Now that's a slippery slope, because once we've done that, kids that have had a continuous glucose monitor and then now you have to go back to poking your finger, not super helpful. But at the same time, I think it's something that needs to be considered definitely on an individual basis, and also going forward in terms of good control in these kids.
Thanks for the feedback. I will definitely direct that at the BGS team that's thinking deeply about this.
Oh, and I was also going to let you know in terms of the 12-month contraceptive coverage, we've already approved that, taken it to pharmacy, our own pharmacy P&T committee, and approved that so that our Medicaid members can have that. That came out of information that we were able to receive from the recent change, obviously, in access for women, and the fact that women, the data shows that women are more compliant if they have access and don't have to go to the pharmacy every month or every 3 months to get that medication. So our P&T approved that right away.
That's great. Thank you.
Great. Any other questions for Ariel?
Sorry, I don't have a hat today, guys. I will continue to be here for the EPSDT discussion. So if you have anything to chat to me or to the group, or any questions that come up, please let me know.
We will just do hats and things just for December's meetings. I did figure out how to do the thing that Doug did, though, so I found that well.
Okay, everybody has to see Doug. Doug, say something so that you show up. Okay, fine.
Oh, I changed my video. I'm sorry.
Doug's on mute. There we go.
Oh,
I couldn't do the antlers though.
You're on the spot now, Dr. Carr.
There
it
you go.
is.
Oh, see,
All right.
there it is.
I'm ready to take to the sky.
Okay, we're gonna go over to Dawn now to kick it off for EPSDT. You're on, Dawn.
Thanks. Let's see, EPSDT. Good morning, everyone. Dawn Moutner, she, her, Aya, Medicaid medical director, white woman, long dark hair, no hat now. And here, bringing back EPSDT only for updates. Nothing has changed in terms of what we told you last time, but some of the questions and requests that you've made have been addressed. So that's why, and we wanted to make sure that there was a space on today's agenda for you to get any questions answered before it goes into effect on January 1. So let's run through a few slides and see how close we get to answering your questions in the slides and take it from there. The reminder for the early and periodic screening, diagnostics, and treatment is that it's going into effect on January 1 with any medically necessary and medically appropriate services for enrolled children and youth until their 21st birthday covered, with no waiver for items that may formerly have been below the line, even if they're still below the line, if they're non-paired, if it's a quote non-covered ancillary service, if it's covered under the state plan, none of those things prevent the need to cover any medically necessary and medically appropriate services for enrolled children and youth. Next slide, please. Here is the guidance that is now available and posted online. You should have seen these come through in different environments, the CCO newsletter, etc. But there are the links. They are live and active for EPSDT guidance document for CCOs, the policy change memo for providers on the ground, the guidance itself for providers on the ground, and the fact sheet for members, which is being translated. Next slide, please. Additional resources are being developed for prior authorization in particular, and for webinars for providers in the new year. The Transformation Center will be sending out emails to make people aware, excuse me, of the availability of those webinars, and they'll be posted as well. And all of these resources will be posted at oregon.gov/EPSDT. If you have specific content that you want to make sure is included in webinars, please feel free to reach out. We'll have that content drafted out on the basis of these materials, but do let us know what's missing and do help us continue to center equity. You are, everybody on this call is a critical partner because you bring perspective that we don't have. So let us know what we're missing. Next slide, please. Questions. Again, not a ton of new information, just some new resources. And here for any questions you may have.
Hey, Dawn, it's Doug Luther here. Can you hear me?
Hi, Doug.
I raised my hand. I was waiting for Lisa to acknowledge me, so I'll just jump in, but
sorry.
That's all right. So some of the document that you guys distributed says that we can use I may not quote this exactly correctly, but use the either prioritized list information or even the prioritized list itself as a quote guidance document, but there isn't really any sort of elaboration on what that means. Is there going to be some sort of clarification? I mean, it seems a little bit self-explanatory, but not entirely, right? Does that mean that we can use guideline notes specifically as they're written? to determine coverage, again, with this overlay of is it medically necessary or not. But so it sort of seems to create a little bit of a discrepancy potentially sometimes.
Thanks, Doug. Specifically, what we meant by that is that it can't be used, the prioritized list can't be used as a firm and final guideline. It can be used as guidance. Absolutely. Use the guidance notes. Absolutely. Use the placement on the list to think about and take guidance on whether this is appropriate for a broad swath of people. And do not deny services to any individual on the basis of one of those constructs without individual consideration. So I think that I just restated exactly what you said. Generally speaking, all of those things are valid. Individually speaking, none of them can be used as a broad denial reason without individual consideration that says medically not appropriate or medically not necessary for this individual. How close did I get, Doug?
I think you got close. I think there's one of the issues going to be, let's say a guide note currently says that something's not covered. And I know you guys are going to work on moving some things, so you may resolve some of these and they'll never become an issue. But if there's a guide note that describes that something is not covered, and then we just decide that it's, I don't mean to sound that way, that we determine additionally it's not medically necessary, I presume we can still use that as a denial rationale that the guideline note states that it's not covered and we determine that it's not medically necessary. Because of course, we're going to get into a lot of discussions where, my medically necessary service is your, ridiculously unnecessary service, right? And so kind of curious where the guide note would come into play there if we had a difference with a provider who thought that our assessment of medically necessary was inaccurate or inappropriate.
If you can make the specific reference that says, we use this as a guideline, but we reviewed the case and have determined that it is not medically necessary in this specific case, then that is what you can take to hearing, and an ALJ will make the determination. But it sounds correct to me. And policy team, Liz, Jessica, Laura, please back me up if you think I've got that, wrong, and we'll have Nathan make sure. I don't know that Nathan is able to join us this morning. He got called into something, but we'll have him back us up.
Hi, Dawn, this is Jessica. And you're correct. It's the individual case review of medical necessity and medical appropriateness. It's just not using the prioritized list as a blanket denial.
Doug, did we get there? As long as there has been an individual review, the evidence review holds, right? Those guidelines hold. But as long as there's been individual review, and that's where you're grounding your determination, I think you're on track.
Yeah, thank you, Don. That's helpful. I mean, I think we're going to probably we'll have some cases that sort of test our approach, right, over time, and we'll all learn where we're supposed to end up on these, because I would argue we already do that, right? We might invoke below the line pairing, or a guide note states that something's not covered, but we also do a medical necessity review. At least that's what we do at Care Oregon. So that won't change that much. I just think it sort of changes the perspective of the providers as to what's covered and what's not covered. And so it'll be interesting to see how this pans out. But thank you for the clarification.
Agreed. I think Laura might have been next.
Hi, thanks, Dawn. I was reviewing the guidance document that was going out to members. And did you say, Dawn, that has already gone out or it's available?
Jessica, that's posted, is it not?
Yes, it is posted and in the process of being translated at this time.
Okay, I think I just want to put this out there. I think it's difficult, and I know we've had conversations about the handicapping malocclusion and the orthodontic benefit. I think it's really difficult, especially since this is made available when we don't have guidance around that. I don't think anything is permanent. We had a meeting with providers, and I think my dental director is on the call this morning, but nothing has been solidified and nothing really is in rule if we're going to go that route. So now we have this document out there saying that this is available when we have nothing to go on for that. So I think I would just encourage the finalization of this if we can, so we know what we're going to be doing as far as medically appropriate and getting the guidelines around that.
Noted. I appreciate it. We're moving as fast as we can on HCM. I recognize the concern, and I appreciate the partnership of the CCOs as you bring your own subject matter expertise to bear. We have the KeyPro team for the fee-for-service group has their orthodontist and oral surgeon dental team on track to support from the fee-for-service end, and we're going to ride this out with you. So thank you. And we'll get all that material to you as quickly as we can. Holly Jo.
Well, you just said that that these medical necessity reviews could end up at the ALJ level, at the hearing level. And I guess I'm just trying to wrap my head around that. The ALJ, in my mind, has always been, clarifying and reviewing whether or not the rules were followed. And so I'm just interested in how a lawyer is going to make a medical necessity decision.
Ideally, the ALJ does not wind up in a position to be faced with a medical necessity decision. And ideally, we have enough clarity with using the guideline notes and using the evidence review of HERC and using the individual level review at whatever level of medical expertise is appropriate within CCO or a fee-for-service to resolve all of the medical clinical decision-making questions in terms of medical necessity and appropriateness. I think we have a very robust framework for that. It's just that with this shift, there's enough uncharted territory that we don't know what's going to wind up getting appealed all the way through and what they will be faced with. But I think the framework is robust, Holly Jo, and I think you're on track with the expertise that you need, because we've been doing this, as Doug said, all the way along for the most part. And so while it's a headline grabber to say Oregon's doing EPSDT, it is a myth to say we weren't doing EPSDT before. We have always done the vast majority of EPSDT. And for those services that have not been covered in the past, that's where we're in uncharted territory. But I think you all have the structures in place to implement this successfully. And we're here to partner in the dialogue as we go along.
Thank you.
Dawn, I have a question in the chat for you. It's just to me directly. So additionally, does quote unquote no line apply to EPSDT also? The document only calls out funded, not paired, and below the line. I'm going to put it in the chat string for everyone so you can visually see it. So I'm going to go ahead and hit. There you go.
Lisa, I think you're able to chat with everybody, but we can only chat directly with you. That's how the meeting was set up. just so you know.
No line applies to EPSDT also. We were talking specifically in that document about the line, about the prioritized list, but absolutely. The bottom line is, if it's medically necessary and appropriate, it's covered. Line, no line, on the list, not on the list. That's the rule of EPSDT. And whatever we've said about the context of the line doesn't mean that if you don't have a context for the line, that you have an out, that we all are looking for a way to not cover it. If it's medically necessary and appropriate, and this is an enrolled person under the age of 21, it's covered. How close did I get to answering that question?
I'll wait for the person to reply to me. Jennifer, can you change?
This is Ariel. I'm just going to pop in here that the coverage of things that are for kids that are EPSDT appropriate, even if they're on an uncovered line, that's what we've always been doing. It's the exceptions process just amped up. So hopefully that helps.
Thanks, Ariel.
Thanks for giving some structure to that answer, Ariel.
Yeah, the chat strings for 2023 will be, y'all can chat to everybody. And so Jennifer might be able to change that in the moment again, where y'all can chat to everybody. The 2023 Zoom meeting, I didn't restrict it. So I set up the Zoom and I didn't restrict it because I don't even know how to do that. So
I appreciate the chat. There's a lot of crowdsourced richness and education that happens in this chat.
So Jennifer, if you can try and change that in the moment, you can try and change it so everyone can chat to everybody. But just so you know, for 2023 meeting Zoom, you'll all be able to chat everybody because I don't know how to do it otherwise. Any other questions for EPSDT for Ariel, Dawn, and others that are on this call? Thank you, Jennifer, for changing it. Everyone should be able to chat to anyone and everyone now. You can always chat me, but you know, it's nice to chat each other.
Thanks for the work that y'all are doing out there in the community, supporting access to care coordination, as well as the care, as well as the social determinants and health related services. I think what CCOs are doing and what Oregon is doing is really going upstream to try to address the root causes of health inequities. And you are the people, and you're on the teams that are not only implementing and executing how to get these services to people, but bringing back the learning that helps those of us at the state do a better job of providing you with that support. So thank you. And I hope that the holidays are safe and supportive and happy as they can be in this world that has so much still to work through. Thank you for your partnership.
Thanks, Dawn and Jessica. Let's go one slide forward, Jennifer, please. Oh, I thought that we had I thought I had a different slide here. Well, we'll let's go. What's the slide after this? Can you go one more slide, Jennifer, please? Let's do this slide for a second. So before we go on break, I want y'all to look at when we get back, we're going to be doing breakout rooms for the Zoom or for our QHOC planning discussion. So this is the how to connect your phone to your computer. So if you joined your audio by phone and you joined your computer for video and, you know, for looking at two screens or whatever, you need to connect your phone to your computer. This is how to do that. So please look at this slide. And then we'll go ahead and Jeannie take a kind of a good 5-minute stretch break, you think, and then come back and we'll do the planning and retreat part. So we'll do breakout sessions, etc. So let's go ahead and go back a slide. Do you want to do 10 minutes, 5 minutes, Jeannie? What do you want to do? When you want to come back?
I would say 5 if people are fine with that. So if we can give people back extra time at the end of the discussions, that would be ideal, as long as we have everybody here to lead those discussions already.
Okay, let's come back at, I'm gonna say 11:05 just because it sounds a little better.
That's
easier.
perfect. Yep.
Let's come back at 11:05, everyone, and we'll carry forward with the QHOC planning discussion. We'll see you back in a few.
Hello, it's Jennifer. Let's see, thanks for advancing slides. Jeannie, are you back? Don Mont, are you back?
Yes, ma'am.
Okie dokie. Okay, let's see here. We're going to do 2023 planning. This is our first attempt at this. Normally, what we've done in the past is we'll do like a, I don't know, a charter review, and we'll sit there and look at the charter and we'll go, looks good. This time around, when we were talking as chairs, we thought, let's do a little bit more than just a charter review. And so we thought we'd do kind of an actual conversation, kind of do a little QI. Jennifer, it looks like some may not be able to chat to everyone. So if you could check on that, that would be great while we're working through this. That'd be wonderful. So we're going to spend a little time doing kind of some breakout rooms and discussion, because we thought it'd just be easier to do that in a smaller group. We'll do breakout rooms, and then we'll do some polling as well. So we'll do a couple different methods. Let's go ahead and go to next slide. I'll cover a little bit of what's in the charter and in presentation style, and then we'll do discussion. So I'll go purpose, goals, objectives, and history. That's stuff from the charter, that it's kind of in essence a charter review. Future QHOC planning, breakout rooms, and then we'll do a breakout room report out, and then a large group discussion. We'll be using Jamboard and polls. So if you're not familiar with Jamboard, it's kind of like if we were in a room. It's an affinity exercise using Post-its. You can do it electronically. So it's an ability to use it virtually. So you just need a computer. If someone can give a chat to see if you can chat to everyone, that would be great. You want to give that a try. Next slide. QHOC purpose. This was literally taken directly from, thank you, Kristen, for trying to chat. So it looks like it works. This is taken directly from the charter. Provide a forum for community leadership for physical, behavioral health, and oral health. So again, that integration, oral health, physical health, and behavioral health. Develop community improvement strategies from identified trends in quality and compliance. Serve a liaison and consultation role to OHA for clinical quality aspects of implementation of the Oregon Health Plan, including a focus on clinical guidance, benefits, implementation, and quality assurance policies. Identify integrated approaches and strategies to improve health outcomes. Provide mechanisms for community programs to reach coordinated care organization, clinical leadership for policy implementation issues that support quality delivery of healthcare across the spectrum of care. Share best practices to community partners for issues and concerns regarding quality initiatives. That's good to refresh. Next slide. I was going to give my editorial comment, but we'll just save that for breakout rooms. QHOC goals and objectives. Review, discuss, provide input on changes and advice regarding clinical policy implementation for HERP, Pharmacy and Therapeutics Committee, MAP, and other relevant OHA programs. Support clinical population health initiatives and standards. Share best practices and approaches amongst CCOs and OHA. Evaluate waiver required external quality review organization EQR findings and performance improvement projects and implementation review. Quality metrics monitoring and performance improvement plans. Advise on OHA quality strategy development and implementation. And collaboratively develop and improve best practices for contractual quality expectation reporting requirements for CCO and OHA following CMS's regulations. Next slide. We'll want to, when we go into breakout rooms at some point, hopefully, have those as a reference. I know we're kind of going through these fast, but we can always go back to them. But for those that hopefully have 2 screens, you can have both open. Literally, this is just me just putting what I know down from some history. QHOC has existed long before Dawn and I. And I say Dawn and I because Dawn and I are your current sponsors of QHOC. This meeting has existed way before Dawn and I. I came in 2015-ish. Dawn, how long have you been here? I don't even know. 3 years. So this is known as the Medicaid Managed Care meeting. Then it was the Quality Health Outcomes Committee, and then, you know, it's evolved. It's been in many forms as a managed care medical and quality meeting. Learning collaboratives integrated as part of QHOC when CCOs were formed, I believe, and became regular practices approximately in 2015. And then learning collaboratives have been a part of QHOC at different frequencies, like, you know, how often we had them at different points in time since I've been a part of QHOC. They were full virtual meetings, necessitated obviously by the pandemic, you know, with obviously the pandemic, March 2020. Next slide. So breakout rooms. Since we're not gonna, you know, I was just gonna do just randomly assigned to breakout because that's how Zoom does it unless you actually sign up ahead of time. You'll have the same question prompts in the breakout room. So basically Zoom will send you all to breakout rooms. I'll drop the question prompts into the chat string here. And those are just guides. So they're not exclusive for the conversations. Just like if we were all hanging out in HSB in Salem like we used to, you'd all be sitting around a table and we'd be talking about our charter and say, what is it that we want out of these meetings? Y'all used to drive to Salem and we'd sit there and go, what is it we want to do in the next year? Ideally, you'd select a note taker in each breakout room so that you can send it to the chairs and myself so that we can talk as chairs in our next chair debrief meeting about how we're going to take what you want from this meeting and put it into our planning for next year. So then Doug, Jeannie, Laura, Dawn, and I can take what you want from this meeting and try and actually put it into the form and function of the meeting design. So if you could identify a note taker, that would be great. And then that note taker will, you know, send us the notes, and then I'll work with the chairs and Dawn to work that out. Any questions about the breakout room? Let me get like I said, the polling that will happen after the polling will take care of some of the form questions, like should the meetings be virtual or not virtual? How many learning collaboratives a month are we going to do? What kind of learning collaborative topics would be good to do? Those are all things that I put into the polls and the Jamboard. You, by all means, can talk about those in your breakout room, but the breakout room questions are more towards kind of goals and objectives and purpose of what you're convening for. So the form part of our time are more in kind of the polling and after our large group discussion. The breakout room discussions are what goals, objectives would you like to change? What clinical priorities would you like to focus on in 2023? That's kind of more the big picture conversations for your breakout room discussion. And again, those are guides. Any questions, anything to add, Jeannie, Doug, Dawn? A real quick question, Lisa. So will we have somebody from OHA in each breakout room to help and has these present to kind of keep us going and online or on track with what we're discussing?
No, because there's only like 2 of me, or 1 of me and there's Dawn.
So how many, so are we designating somebody in each breakout room then to kind of,
Yes, define your own note taker.
okay. And is it clear, is it clear the questions that you want us to discuss? Or can you put them up somewhere so that we all see them?
Yeah,
Or do we have
I'm
to
going to
open
drop
up
them
our-
in. I'll drop them in the chat.
Okay. Okay, great. Thank you.
So I will drop them in the chat. And again, they're guides, but you should have, again, the 2 slides. So, and if you don't have them, they're posted on the QHOC website.
Yeah,
But
I
we
have them. I'm just not sure everybody will have them. But yeah, if maybe the note taker designated for each group can bring them up and make sure they have those slides in front.
The QHOC purpose and goals, slide 26, I'm sorry, slide 27. And then I'm gonna create the Zoom rooms. We've got 29-ish people. I'll probably create, I don't know, I have to do math. If we do 3 rooms, that's 10 people. I'll create 4 rooms. And then the computer will just automatically assign right now. And then I'm gonna drop the questions in the chat, and then we'll all just Zoom away, and then everybody goes. And then if you like Jennifer, you're more than welcome to join a room. But if you don't want to join a room, you can leave a room. And then we'll stay in the room and we'll have a discussion. And again, the questions are guide, but it should be at that macro. We'll talk about the frequency and stuff after the large group. Any questions before I hit the Zoom breakout room button and we all leave each other? Okay, I'm hitting the button. Open all rooms. Randomly going. Hello? I think I'm in a room. I don't know if I'm in a room. Hi, Jennifer. Oh, I think.
Hey, Jennifer, can you hear me?
Yes, I can.
We didn't see the questions in the chat in our breakout room, so we didn't know if Lisa had put them in there or not.
Oh. Well, I'm not in a room, so I don't know.
Normally, if you put them in the general chat, it'll show up in the
Okay.
breakout rooms, and we couldn't chat you because we can only chat the people in our breakout room. So that's why I hopped back to see if.
Okay, well, let me see if I can find the poll. Hang on a second. So is it just the first poll, I guess, maybe?
We don't see anything in there.
Okay. Let's see what can I do. Let me just launch it. I don't know. Hopefully that doesn't do anything, but I'll launch it, see what happens.
Okay. Oh yeah, we can see the poll now. I'm gonna head back to my room.
Okay, sounds good.
Let's see if you can you all hear me? Maybe someone give me a thumbs up.
Yes.
Great, thank you. Hopefully nobody was in mid-sentence. Could you see the broadcast messages when I was broadcasting messages?
It briefly came across the top of my screen and then disappeared.
Oh, okay. Because apparently when I tried to send you the questions, it didn't work when I did it in chat. But I don't know if it worked for some and some it didn't. But hopefully you had a good discussion. We're going to do a sharing of what you talked about in your breakout rooms. I already teed up the room that I was in that I would be throwing somebody under that bus. So just as a reminder, kind of we were talking about the questions were what was kind of the purpose of what are the goals and objectives you'd like to adapt and change? What clinical quality priorities would you want focused on in 2023? And or those were just guides for the discussion. I will go ahead and start with the group I was in to begin with, and then I'll just kind of go round robin. Anybody in my group want to start? Juliana / Amanda, who took notes?
I'm happy to. And Juliana, if you want to, you can supplement in because I have my notes in front of me here. So the overall theme of our conversation was just the changes and the evolution of QHOC over the last couple of years with the pandemic and you know how we're adapting and focusing on different things. And the theme was really that it's changed a lot in the fact that there used to be, you know, a lot more collaboration, a lot more upstream notification of things that were happening and changes that were coming down from the OHA level. And that's something that's greatly missed in our group. And we talked about a number of clinical and quality priority areas, including health equity and its alignment with the OHA, goals and how the social determinants of health work fits into that mix. To make sure that there could be some policymaker, information brought to the group to understand the why behind the policies that we're having to implement at the CCO level. We talked about relationship building and how that's really important for this group. And so with that came the thought of, in-person versus hybrid meetings. We talked about the 1115 waiver and how we would like some clear direction and thought sharing as it comes to the implementation of those benefits. Behavioral health integration, the alignment between the social determinants of health metric and the HSRN benefit, and how we can really work to align and avoid duplication of work. There was more discussion about how to bring that, the why versus, from the policymaker on, from sections to make sure that we're understanding the complete trajectory of the policies that we're trying to implement on the CCO level, and better understand what the problem is that the policy is trying to solve. And so overall, the real theme was upstream and collaboration and bringing in things that really help us understand the work we're supposed to be doing.
Nice, Amanda, thank you. I'm just going to assume the people who are on camera are giving the report outs for their group. Oh, that's the way to get Kat off camera. Katrina, are you giving a report out for your group? Nope.
No, I think that it's going to be Jeannie, and I'm going to take myself off of camera too, because I didn't.
Okay, Jeannie, are you giving the report out for your group? She's like, let me find my notes. Who wants to go for their next group? Laura's got her hand up. Nice. Thank you for the cue. Go for it, Laura.
You're so welcome. So we had a really great discussion in our group regarding QHOC and the things that we would like to see. And so some of the goals and objectives we would like to see or get more focus on is the collaboration between our behavioral health, our oral health, and physical health integration with social health. And so maybe doing more learning about prioritizing the social determinants of health and those measures and metrics, kind of like doing learning collaboratives regarding those, regarding oral health, behavioral health, social service learning collaboratives that we know there's lots of projects going on, but hearing more about them throughout the year. More intercommunication with deliverables, because some deliverables tie to others, and just having that golden thread through all of those as well. We talked about more of a CBO presence at QHOC, representation regarding CBOs being at QHOC so that we can better integrate them into everything as well. We would like more ability to be more collaborative with OHA on advising and developing of projects and measures so that the QHOC team is more aware and can provide more input to OHA about some of the things that are coming down the tracks or people are looking at. We also kind of talked about having more of the different meetings and committees that happen at OHA, kind of give an update at OHA, making sure that things are being aligned through and that the information that is shared in one group is actually shared in all the groups, and that is a understanding. So if something is going to maybe the CCO compliance and contracts meeting and CCO ops, that it also, if it's a QHOC part, it also appears at QHOC as well, and just having that cross communication between department or between the meeting groups. We did also want a learning session on QAPI, and because we haven't had one in several years, and just how each CCO might be conducting their QAPIs and how they're writing them up. And then the sharing of information regarding the social emotional metric along with the language access metric. And am I doing a lot of word spilling now? Did you get it all?
That's why you took notes, because you're just going to email it to me.
Lots. And they're on my to-do list.
Thank you so much. Okay, Laura's going to send me that list, and she's the chair, so we'll be having lots of discussion. Great conversation. Jeannie, you're up next.
Oh, I was just going to put ours in the thing, but I think what we came out with were, what would we add, adapt, or change at the very beginning? I think it feels a little bit like a report out, and Dawn has said that in the past. So how do we encourage engagement in between discussions? And what we had practically thought about was that this small group engagement, where we have breakout rooms after discussions, would be helpful. So for one of the examples we gave is Ariel's giving an update on HERC. There may be certain parts of the discussion that are truly just updates, and there may be other areas of HERC that she would like feedback on. And specifically having her say, you know, here's my presentation, but here's the areas I need feedback on. We're going to have a small breakout room after the HERC discussion, so people in a small forum can give feedback specifically on these areas and any other area that they want to, but these specific areas might be focused on. So OHA working with presenters to prepare them, saying, we want this group engaged. Here's your presentation, and get it. Please put any questions or areas that you would like engagement from the group on, or feedback specifically on the group. And then allowing time in the breakout rooms where people might feel more comfortable giving feedback. In front of 70 and 80 people, it can be uncomfortable, but small groups of 4 to 6 is a little bit easier. So practically that's one thing we talked about to increase engagement. Using polls or other Zoom functions frequently to keep people engaged is helpful, along with those breakout rooms. We talked a little bit about what else in that part of ongoing. Let me look at my notes. I think that was all about the kind of current goals. We then looked at the current goals and objectives and said, are we really doing these? And I think one of the word collaborative, really popped out to us. Like, are we truly being collaborative? In what areas are we as participants in QHOC making sure that we're reading the agenda and preparing ourselves to be engaged and to be collaborative? Are we looking at the topics? Are we doing everything? And I said, definitely not. I'm not always prepared, and I need to do better in that area. And we took some personal responsibility for that. And we also said that looking forward in 2023, a way to be more collaborative, as an example, would be to say, we have a lot coming up with this waiver, specifically around the health-related social needs and populations and definitions and metrics and so forth. What would it really look like to have some of that work be done collaboratively with this group and with OHA going forward, such that if you look at the example of our ACs, right, there was the air conditioners. It was like, hey, we need to get these air conditioners out. Each CCO went out and said, okay, we have this list, but that list doesn't necessarily jive with the list. We're not sure whether that came from. There wasn't a clear kind of direction. CCOs may have done individual things, and then we get together and then OHA says, hey, wait, but we need this, this, and this as well. And it's like, we're kind of doing work and then getting some feedback and then trying to do it. It's like, maybe if we were involved in the process at the very beginning, being more active and saying, hey, we need to be involved in this development of that process. And had that been more collaborative, it might have been it could still be a little bit more successful, or there may be just less work later on added on. So whether or not all of that happened, that may have been the perception of some of us in the room, but likely just to say collaboration going forward, especially on those implementation things with the waiver going forward, I think a lot in this group might be really, really helpful. We know there's a lot of work going on in smaller groups within our own CCOs in the state, and maybe having us involved, or bringing that kind of overall perspective. Look, we're running this work group on the waiver, this work group on the waiver, and this work group, and this is how we want the medical directors involved in that waiver strategy discussion, would be really helpful. that would be a very collaborative approach going forward. The other area that we were talking about specifically is in the area of behavioral health. We used to have, I think, a lot more interaction. We still have some dental interaction here, but I feel like we're having a little bit, and our group felt that we were having a little lack of cohesiveness and integration with the behavioral health work. For example, Mike Franz used to be that kind of guy who overlapped both areas. He was really good about being involved in both meetings. He's not here anymore, as many of you know, and I think some people are good about doing that, but there's no real kind of connection on behavioral health strategy and physical health strategy going forth with that integration, and wondering about how we are collaborative in this format with our behavioral health partners and OHA looking forward, to have that information and cross connection really happen more. I like to attend the behavioral health CCO medical or directors meeting. I think that's a great meeting. I can't always make it, but not everybody has that luxury to do that. So wondering how we connect those two groups in a better way, specifically around strategy going forward. And then metrics. Really think that looking at metrics and doing one of the things that we used to do prior to COVID was bring forward those groups. And one of the reasons why Kat put in the chat that how are we performing is to bring forward those groups that are really doing well, those CCOs that are really doing well around metrics. And specifically, we brought up vaccination since it's been really difficult for all of us to make, with the exception, as you can see there in 2021, Pacific Source did a great job in their areas. And maybe saying, what are you doing? How Pacific Source, how are you doing that, bringing that back to the majority of the group, and then breaking into smaller groups and saying, here's some of the barriers, here's why we are having a difficult time, or just being more open about, you know, what could we do better around the vaccination, and oh wow, eye opener, one CCO out of 15, are we 15 or 16 now? Anyway, one CCO is doing well and the rest are struggling. Is there something systemic that needs to be dealt with? How do we look at this going forward? If 14 of us are struggling and one is doing well, we all need to get on the one's train, or we need to look at what else is affecting this such that we're not able to get to that same level. So just having more insight and transparency around that, sharing best practice, developing best practice, bringing that back, because I think it was difficult. We did used to do that, but we haven't done it as much, and maybe bringing that process back. Team, in my group, anybody else, did I sufficiently recap our discussion?
That's great. We had some common themes around the waiver kind of implementation, and also crossed it with potentially the CCO ops. And so that there's some good discussions for Don and I to take back within the OHA teams that are working on the waiver policy and implementation side. So really great. I think that's 3 of the 4 breakout rooms. Am I missing one of the breakout rooms? And if so, who wants to step up? Is it Dawn? She's like, yep, it's me.
You made me do it. Well, I love to hang out with the brilliant people who attend this meeting. I love small groups where other people talk. That's wonderful. A lot of resonant themes have come up. Jeannie, those were resonant themes. With the shift in metrics and scoring, very specifically, a request was made for a more formal space in which conversation dialogue could happen, feedback around metrics and scoring as implementation rolls out and challenges appear on the ground, and whether this is a meeting where that kind of ongoing dialogue can and should happen. That was one question. And whether with that, the metrics and scoring leadership could come to this meeting, attend to hear some of that. The the sharing of best practices here is highly valuable. Also, the sharing of pilots and innovation. Again, like Jeannie was saying, if there's one amongst everybody who's getting something done, even if we aren't at the point of best practices, sharing that innovation for the local teams to figure out how to use that learning. There was some conversation about data, focusing a lot on data and data collection. And so discussing here how data are being used, and in particular providing some what will probably be TA on how to use, especially as Realty and Soji data come to fruition, but not only those, how to use the data effectively to improve inequities. The question about engagement during QHOC, that is to say the top down, here's information sharing, updating, versus, for example, sharing questions ahead of time. Hey, this is something you're going to be asked about. Here are some materials if you want to think about this. And then the small groups or breakouts or however we want to engage. I like the polls. And then with regard to clinical and quality priority areas, Safina came out with a beautiful top 4 of social health, that is building of a social health network and how we need to expand our thought process, behavioral health, access and engagement, and equity. And I tacked onto those reproductive health. We all tacked and came around with reproductive health, oral health, and integration. That is to say, this whole person centered care that came up before already. And then also HIT and CIE, back to the data, but how to connect. Team, how close did I get?
A couple new ones, HIT, and that's a good one to add.
Team, how close did I get? Room 4?
Perfect.
Thank you. We had a lot of coughing and sniffles in room 4.
Oh, people are getting sick. Jennifer, would you mind putting up the slide deck for me, please? Thank you. Those we have some themes, but we also have some in each room some specific pieces that I think each one added a little bit, which I always appreciate, which is why we do breakout rooms with individual people who have we all have our own thoughts to contribute. So as a reminder, sounds like a couple of our chairs have their own notes, but if you can just send us the notes, that'd be great. I'll collate them in preparation of our debrief meeting, where we'll try and have a discussion to plan this out for everyone. So we will be thoughtful, and we'll try and make a plan, everyone. That's what you get when you get to be a chair. So thanks for the large group discussion. Now we're gonna do the form part. So I have a couple polls out here. So the polls are actually running live anyway. So how I guess they're just out there. How you should be able to see the poll. Can y'all see the poll?
I don't see a poll, Lisa. Am I the only one?
How does someone see a poll? Let's see here. Hit the poll button down in your little Zoom bar down at the bottom. Do y'all see a poll?
I saw the poll before. There was one before that came out.
Yeah.
But I don't see one now.
When we came back in from our rooms, there was a poll up, and I went ahead and I responded, but
yeah, ditto.
Yeah.
Yep.
I don't want to end the poll. I can end it.
Can you see how many people have responded to the poll?
Some people, like 2. Yeah, it says 22 people-ish.
have responded.
Yeah.
And you have 26. Some
Okay.
people are probably on the phone and can't
Yeah.
respond. So
Okay,
that's pretty
so-
good results.
So I guess I can show you. So I'm gonna now drop you all a Jamboard link here.
Hey, Lisa, I may consider doing this poll again at the beginning of QHOC. We had 60 people earlier, and now we have 20. So I'm just curious if maybe we should, this
Yeah,
is
we can
definitely
do
good for
it at the
now,
next
but
meeting too.
yeah, just wondering if we should repeat it and see if we get the same results when we have 60 folks.
Yeah, I can do that. I'm gonna drop a Jamboard link. And I'm gonna put mute because my husband's on the phone. So hang on just a second.
Laura, this is Laura. Can you hear me?
Yes.
Could you copy the Jamboard link? Maybe Lisa could send it out for those of us that are on the phone. Just if we wanted to add anything to it, we could.
Yeah, we'll also email it out because I can just keep it open. But basically, if you are familiar with Jamboard, you can go in and it's a virtual post-it whiteboard. And I'll just keep it open, but you basically pick any one of these little post-its. I'm going to start sharing my screen here. And you can start to answer the questions where I've asked what learning collaborative topic suggestions would you like to add? So it's just a way to add people's thoughts. So anybody who has a link, oh, you're probably looking. You should be able to see the Jamboard. You just click on any colored post-it and you should be able to write in your ideas. So I just put the Jamboard link into the chat. There's multiple Jamboards. Let me move this now.
Just an update, Lisa. In order to edit, you have to have a Google account. That's what I got. It just said in order to edit this, you have to be a Google account person and sign into your Google. And
Oh, seriously?
Yeah, I'm not a Google member. So, I mean, I probably could go find it. I think I am for my kids' classes. But it's on my personal computer, not my work computer. So I could just put some things in the chat though.
Okay, you all just put it in the chat. Learning collaborative topics.
Yeah, Lisa, I put ours, I already emailed you our list and everything, and I have ours in there from our group, but I can't access it either.
You guys can't do Jamboard? You guys haven't, okay. Sorry.
No, it's okay.
Hey, so just a really quick note, you don't actually have to have a Google account. You just have to sign up through this thing. You can put in your own work email. You just create an account and then you can hit the button that says I want to use my current account.
Thank you, Juliana.
Yeah, because we even used it here and I didn't know that. But Juliana just kind of let us know. Or you can just put them in the chat and I'll add them all, but I'll leave it open. And then I guess to Jeannie's point, I'll keep, we'll just create another poll, Jeannie, at the top of January's QHOC, or if you, do you want me just to make a survey, a quick survey monkey and send it out post notes? And not wait till January's meeting?
Yeah, you might get more response if you do a survey. Yeah. That might be possible. I do like what Bhavesh put in there, or Dr. Rajani put in there, one other type of meeting frequency suggestion, virtual monthly, and then an in-person quarterly. Because I do think if you go just hybrid, you're not going to get very many people in person, or we're all going to come different months or something. But I really like that suggestion because that gets us in the room at least once quarterly. So if that were on the poll, I'd vote for that.
Okay. then I can do that too. So what I can do is make a Survey Monkey and then send that out before the end of the year. Anybody can add to it in the chat string. And then I'll just add it to the end of the year kind of planning that we're doing. And then I'll also confirm that everyone will send us the notes. We all, hopefully as a chair, and everyone will send me their notes from the breakouts. We all are meeting hopefully before the next QHOC, so probably after the holidays, but before the new year. So I'll have somebody work some magic in the calendaring. I'll get a Survey Monkey together. I'll update it based upon Bhavesh's insights. Thank you for updating the poll yet again. And then I'll also reiterate, you all should have gotten 2023 Zoom meeting appointments. So if you're on this call and you didn't, then that's a problem, because I scheduled all the 2023 except for OHA staff. So OHA staff, you haven't gotten it yet. All the external people got it. So if you're outside of OHA, you should have received your 2023 meeting appointments, Outlook appointments. If you did not, then you need to email me, Lisa T. Bowie, or you can email the QHOC website contact, and I still get it. I'll be doing the OHA staff ones here this week. Then those individuals who got the Outlook appointment will be the ones who also get the survey for next year and saying, hey, what frequency do you think, or would you like to propose if we're doing anything outside of virtual? That's those who will get the Survey Monkey. And then I'll also include the Jamboard link in case anyone wants to provide insights into learning collaborative topics. And then we'll kind of round out this kind of planning conversations with our chairs and any other insights, and we'll see what next year brings. Any other last comments, Dawn or Jeannie?
Well, I will say, Lisa, that I did get some feedback. I did get feedback that this was one of the most engaged meetings because we were able to get into the smaller groups and actually provide feedback kind of on a smaller group level. So I think the sooner we can implement that kind of change, the better.
Of course. And I have multiple hats that we can always bring into any meetings. We don't always have to wait for the holidays. Everyone have a safe rest of the month. We know there's many holidays that everyone celebrates, so please take care of yourselves, and we will see you in the new year. Thank you for your time. Bye.